Imagine hiring a contractor to fix a persistent, annoying leak in your roof. They come in, they install this heavy-duty, permanent steel plate to patch it up, and, they tell you you're good to go.
Right. Problem solved. Right.
Exactly. But then, over the next 10 years or so, your house naturally settles. The wooden beams age, they shrink, they shift around with the seasons, but that steel plate,
It's not moving anywhere.
right, it doesn't move. So eventually, that rigid, immovable fix starts tearing the aging wood apart. It sets off this chain reaction of structural damage that is, honestly, infinitely worse than the original leak. And today, we are looking at a medical intervention that essentially did exactly that to the human body.
Yeah, we are really looking at a true biological collision course here, taking a permanent static piece of synthetic plastic and installing it into an environment that is profoundly dynamic, hormonally shifting and constantly aging.
So we are launching this deep dive into one of the most complex real-world medical puzzles facing clinicians today. Our mission is to really explore how the medical field is trying to manage the concurrent presentation of two severe colliding issues. On one hand, you have severe tissue dryness, which is clinically known as genitourinary syndrome of menopause, or GSM.
Right, GSM.
Yeah, and on the other hand, you have the chronic, localized, and sometimes even systemic inflammation caused by pelvic mesh implants.
It's a scenario that forces us to reconcile the natural, inevitable physiological changes of the human body with the unintended, often devastating consequences of our own medical engineering.
To give you a complete picture of how this is managed, we are pulling from a massive stack of sources today. We are looking at the clinical guidelines from NICE-US, that's the National Institute for Health and Care Excellence, alongside the Royal College of Obstetricians and Gynecologists.
We're also bringing in insights from the British Society of Sexual Medicine, which are crucial here.
Yes, absolutely. But just as importantly, we are drawing heavily on vital patient advocacy reports. Specifically, data from the Patient Safety Commissioner and the Sling the Mesh campaign.
Because you really cannot fully grasp this issue just by reading surgical textbooks. You have to understand the clinical literature, sure, but you must equally weigh the lived experiences of the patients who are actually navigating this reality. The guidelines tell us what is supposed to happen, but the patient advocates tell us what is actually happening.
Okay, let's unpack this. To understand why this collision is so devastating, we first need to understand the baseline biology of what is happening inside the pelvis before the mesh even becomes a problem. Let's look at the natural changes. What is actually going on at a cellular level with genitourinary syndrome of menopause?
Well, GSM is the physiological baseline for a vast number of postmenopausal women. It all stems from a drop in endogenous sex steroids, so specifically estrogen. When estrogen levels fall, the architecture of the vaginal tissue just fundamentally breaks down. The epithelium, which is the specialized surface layer of the tissue, severely thins out, and it loses its rugae.
Rugae. Are those the natural folds in the tissue, like the pleats on an accordion that allow it to stretch and compress?
That is a brilliant way to think about it, yeah. Without estrogen, those pleats basically vanish. The tissue loses its elasticity, it becomes flat, rigid, and incredibly fragile, and the environment itself changes too.
How so? Like chemically?
Exactly. In a premenopausal state, estrogen feeds the natural lactobacilli bacteria in the vagina, which produce lactic acid. That keeps the environment slightly acidic to fight off bad bacteria. But without estrogen, the lactobacilli die off.
So the local pH rises, making it more alkaline?
Yes, and that alkaline shift removes the natural defense mechanisms. So you have this perfect storm. You have tissue that is paper thin, rigid, completely devoid of moisture, and highly susceptible to infection. This causes intense dyspareunia, which is pain during sex, chronic dryness, and recurrent urinary tract infections.
Wow. I am struggling to see how you even approach surgical intervention in an environment like that. We are talking about tissue that is already structurally compromised, practically defenseless, and historically, the medical world's solution to pelvic organ prolapse or incontinence in this environment was to just prop it up with synthetic plastic.
But polypropylene mesh, to be specific, the idea was purely mechanical. The natural tissue is failing to support the bladder or the uterus, so we install a synthetic hammock to provide structural support.
But the body's immune system doesn't just passively accept a piece of plastic, does it?
Never. The moment you implant synthetic polypropylene, it invariably triggers a foreign body reaction. The immune system immediately recognizes this material as an invader. So it sends in the cleanup crew, specifically immune cells called macrophages and giant cells.
And the sources go into some fascinating detail about the physical design of of the mesh here, right? It isn't just about the material, it's about the architecture of the mesh itself, like specifically the pore size.
Right, the pore size is where this turns into cellular warfare. The pores in these meshes are microscopic. Many of them have pores smaller than 1 millimeter. And the macrophages, the immune cells trying to clean up the area, are physically too large to effectively maneuver through these tiny pores.
Wait, really? So the body's own defense system can't even get inside the mesh to do its job?
It gets worse. Because the macrophages can't penetrate the pores, they can't clear out any microscopic bacteria hiding inside the mesh. So the mesh becomes this protected safe haven for chronic infection. Meanwhile, the immune system is panicking because it can't destroy the plastic.
So what does it do?
It shifts strategies. It decides to wall the invader off. It generates a chronic inflammatory response, forming internal granulomas, which are basically microscopic nodules of inflamed tissue, and it builds a dense external fibrotic capsule completely surrounding the mesh.
Oh, fibrotic capsule, like a thick shell of scar tissue.
And scar tissue contracts over time. As this dense capsule forms and fills those tiny microscopic pores, it physically shrinks. It pulls the mesh tight, causing it to deform, buckle, and become incredibly stiff.
Oh, wow. So imagine the tissue without estrogen is like parched, fragile parchment paper. Inserting a synthetic plastic mesh that constantly triggers an immune attack is like rubbing sandpaper against that parchment. The tissue's natural defense and moisture are already gone, making the inflammation exponentially worse.
What's fascinating here is that this pro-inflammatory response is not just a brief healing phase. It does not stop once the surgical incisions heal. The clinical literature shows this cellular warfare can persist for years, fundamentally altering the entire pelvic ecosystem into a permanent state of painful inflammation.
So we have this environment that is actively losing its structural integrity. The parchment paper colliding with an immovable, shrinking, inflammatory piece of plastic, the sandpaper. If the anatomy is this compromised, how do clinicians even begin to untangle it? You can't just go in and rip the mesh out of tissue that fragile, right?
Well, the initial clinical guidelines strongly lean toward conservative, non-surgical management. The primary goal is to try and restore the health of the surrounding tissue. You have to hydrate and fortify the parchment paper before you can even think about doing anything else.
Right. Let's look at the mechanics of that first line of defense. The sources mention non-hormonal options first, like bioadhesive moisturizers. What is the actual mechanism there? How is a bioadhesive different from just grabbing a standard lubricant off a pharmacy shelf?
A standard lubricant just sits on the surface of the tissue to temporarily reduce friction. Bioadhesives like Replin's or YesAVM are fundamentally different. They are engineered to bind to the vaginal epithelial cells. They alter the fluid content and the osmolality of the tissue.
Osmolality. So we are talking about drawing fluid across a cellular membrane.
Precisely. They create an osmotic gradient that actively pulls water into the dehydrated cells, forcing them to plump up from the inside out and trapping that moisture there for days.
Okay, that handles the hydration, but it doesn't solve the underlying lack of estrogen that caused the thinning in the first place, does it?
No, it doesn't. For that, clinicians rely on localized, low-dose vaginal estrogen. We are talking about topical creams or pessaries, like Vagifem or Avastin. The goal here is revascularization.
Revascularization, meaning building new blood vessels.
Yes. By applying estrogen directly to the local tissue, it stimulates the growth of new microscopic blood vessels, bringing vital blood flow and nutrients back to the area. It thickens the epithelium and restores the natural acidic pH, all with very minimal systemic absorption into the rest of the patient's bloodstream.
Which logically leads us to a highly specific clinical strategy mentioned in our sources. Clinicians often use this topical estrogen to treat actual mesh exposures, like when the mesh has physically eroded and is poking through that thinned-out vaginal wall.
The clinical rationale is that by optimizing the tissue health, making it thicker, bringing back the blood flow, the tissue might actually heal itself and grow over the small exposed area of mesh. The medical establishment often prefers this because it might spare the patient from a highly complex, incredibly risky removal surgery.
Okay, we need to pause right here. Because this specific strategy, treating a mesh exposure with estrogen cream to avoid surgery, is the epicenter of a massive controversy between clinical guidelines and patient advocacy groups. We are going to look at both sides of this impartially, based strictly on the source material, because the tension here is profound. Let's look at the patient advocates first, specifically the Sling the Mesh campaign.
The data from Sling the Mesh paints a very stark picture of the patient experience. In their surveys, nearly 80% of their respondents suffered from chronic, debilitating pain linked to their mesh implants.
80%. And their argument is that treating vaginal mesh exposures with topical estrogen is fundamentally an unsuccessful strategy. They argue that it merely prolongs the patient's suffering rather than addressing the root cause. They advocate that any mesh exposure, regardless of how small it is, should trigger an immediate referral to a regional multidisciplinary team, or MDT, for specialized surgical intervention.
Right. To the patient advocates, the exposure is not just a localized failure of the tissue. It is a glaring red flag for a much larger systemic inflammatory crisis happening deep inside the pelvis.
Here's where it gets really interesting, because looking at both sides of this debate, you have to ask, are clinicians just putting out a chemical fire with a long sprinkler?
That's a powerful way to frame it.
I mean, you're hydrating the area with estrogen, sure, but the polypropylene mesh is the chemical source. It's shrinking, it's causing an immune reaction, and it's still actively burning.
Ah.
Does treating the dryness actually solve the problem, or does it just mask the underlying architectural failure of the implant?
It is the defining tension in managing these concurrent pathologies. If we look at the clinical guidelines, the argument is that optimizing tissue health, improving the soil, so to speak, is an absolute prerequisite. Surgery in this area carries a massive morbidity rate. If estrogen can mitigate the symptoms enough to avoid cutting into the pelvis, many clinicians view that as a win.
But the patient groups are saying the chemical fire is still burning and causing systemic damage, regardless of how healthy the top layer of soil looks.
And the clinical literature acknowledges the validity of the patient group's frustration. Estrogen cannot stop a foreign body reaction. Estrogen cannot stop polypropylene from shrinking and hardening. If the mesh is actively contracting and generating chronic inflammation, topical creams are not going to stop the fundamental immune response.
So, if the conservative estrogen approach fails, or if the patient's symptoms are simply too severe to ignore, they are left with surgery. But as our sources detail, just taking the mesh out doesn't mean the story is over.
Not at all. We have to understand that surgical removal of a pelvic mesh is not a standard procedure.
Yeah.
It is incredibly complex and dangerous.
Walk us through what that surgical reality actually looks like. Why is it so dangerous?
Remember that fibrotic capsule we talked about? The body has spent years integrating this dense scar tissue into the surrounding organs. Removal requires highly specialized, multidisciplinary teams, urologists, colorectal surgeons, all scrubbing in together. The surgery often involves making a massive Y-shaped cut inside the vaginal wall just to access the area, carefully separating the urethra from the bladder.
That sounds unimaginably delicate. You are trying to peel hardened plastic away from the organs that store and release urine.
It is painstaking work. The surgeon has to tease out dense integrated scar tissue from the obturator fossa.
Wait, the obturator fossa, we were talking about the deep pelvic side wall, right? So the mesh hasn't just stayed in the soft tissue, it's anchored itself deep near the pelvic bone.
Exactly. They have to unanchor it from the deep muscles and connective tissue near the bone. The risks of catastrophic bleeding, permanent nerve damage, or creating fistulas, which are abnormal, severely debilitating connections between two organs like the bladder and the vagina, are extremely high.
If you're listening to this and wincing, you aren't alone. Just visualizing the sheer mechanical violence required to remove this is intense. But let's say the MDT performs a miracle. The surgery is a technical success. The mesh is entirely removed and the patient heals. Does the pain stop?
This brings us to a really grim reality uncovered in the literature. Even after complete, successful, total removal of the mesh, chronic pain often persists.
I don't understand. If the physical cause, the shrinking plastic, the chemical fire is completely gone, why does it still hurt?
Because of what years of chronic inflammation does to the human nervous system. The sources note that up to 40% of patients report some level of pelvic pain that actually predated the mesh implantation, often linked to the original prolapse or tissue damage. But more than that, years of cellular warfare combined with the trauma of the initial implantation, the chronic foreign body reaction, and the massive removal surgery can trigger profound neuroplasticity in the worst possible way.
Neuroplasticity, meaning the nervous system literally rewires itself.
Yes. It leads to a hypersensitized central nervous system. Essentially, the nerves in the pelvis have been firing high-alert danger signals to the brain for so long, so consistently, that they physically alter their own threshold for firing. The system develops into what is known as a complex regional pain syndrome.
Like the volume dial on a stereo has been broken off at maximum and the speakers are just emitting static.
That is a very accurate analogy. At this stage, Non-noxious stimuli, things that are completely normal and harmless, like the simple sensation of having a full bladder or just light pressure on the tissue, are perceived by the brain as agonizing, blinding pain. The pain is no longer just a symptom of the mesh, the pain has become a standalone neurological disease.
So what does this all mean? How do clinicians possibly manage a patient when the physical cause is sitting in a biohazard bin, but the alarm bells are still ringing uncontrollably in the nervous system?
If we connect this to the bigger picture, it means the clinical approach has to undergo a massive paradigm shift. You can no longer just treat the pelvic anatomy, you have to treat the entire systemic response of the whole person.
How did they even begin to map that out without getting overwhelmed by the sheer number of symptoms?
These specialist MDTs use highly structured, comprehensive frameworks to untangle the mess. One of the primary systems mentioned in the literature is the UP-ONT phenotyping system.
UPME. How does that break down the symptoms?
It forces the clinical team to look at 6 distinct domains. U for urinary, P for psychosocial, O for organ-specific.
Wait, I for infection.
Yes, I for infection. Then N for neurologic and key for tenderness factors. They overlay this with the Socrates pain assessment tool, which helps them untangle the specific character, onset, radiation, and severity of the pain. They aren't just asking where does it hurt, they're systematically breaking down a massive web of neurological, physical, and psychological trauma.
It sounds like it requires a small army of specialists to manage a single patient.
It requires a true medical village. You need specialized pain management doctors who understand central nervous system hypersensitization. You need pelvic floor physiotherapists.
Why physiotherapists? If the mesh is gone, what are they rehabbing?
Because years of severe pain cause the muscles of the pelvic floor to subconsciously clench. They become high-tone and non-relaxing. The muscles themselves become a secondary source of severe cramping pain. A specialized physio has to literally teach the patient's nervous system how to let those muscles relax again. And critically, it absolutely requires psychological and psychosexual support to help the patient navigate the devastating toll this takes on their relationships, their mobility, and their fundamental quality of life.
It is a staggering amount of healthcare resources required to manage the aftermath of what was originally marketed as a simple structural fix for aging tissue. Which brings us to why this deep dive matters to you, the listener, even if you never face this specific medical issue in your entire lifetime.
It offers a profound, unavoidable lesson in the philosophy of modern medicine.
Exactly. It perfectly illustrates the vital importance of individualized, holistic healthcare. It proves that treating the human body is not like fixing a car. You cannot simply install a permanent synthetic part into a dynamic, aging, hormonally changing environment without deeply considering the long-term systemic consequences. The body is an ecosystem, not an engine block.
It also highlights the absolute power and necessity of patient advocacy. The medical literature we're discussing today, the mandated multidisciplinary teams, the shifting of clinical guidelines, much of this occurred because groups like Sling the Mesh refused to be ignored. Without patients speaking up about their lived experiences, the medical establishment might never have recognized the true scale of these chronic complications.
It's a testament to patients trusting their own bodies and forcing the clinical data to catch up to their reality. But I want to leave you with a final, forward-looking thought to mull over. Our sources mention that the medical field is, thankfully, learning from this biological collision. They are actively investigating next-generation strategies for pelvic repair.
Yes, the focus is shifting entirely away from permanent plastics. The literature highlights research into melt electrowritten biodegradable meshes.
Melt electrowriting, that sounds like 3D printing on a microscopic scale.
That is essentially what it is. They're using a material called polycaprolactone. The fascinating thing about melt electrowriting is that it allows engineers to program the exact microarchitecture of the mesh, so it perfectly mimics the mechanical properties, the stretch, and the elasticity of natural vaginal tissue.
So it moves with the tissue rather than fighting against it. But you said it's biodegradable. How does the body not just collapse again once it dissolves?
Because it is designed to provide temporary support specifically while the body heals. It acts as a scaffold. While the polycaprolactone slowly dissolves over months, it encourages the patient's own cells to infiltrate the area and lay down their own natural collagen. By the time the mesh completely degrades and leaves the body, the patient's own reinforced tissue has taken over the structural load. No permanent plastic left behind.
It leaves us to wonder in the near future, will the era of permanent synthetic implants be viewed as a blunt, archaic tool, like bloodletting or using leeches? How will the integration of biodegradable tissue engineering fundamentally change the way we age, heal, and repair our bodies?
It suggests a future where medicine works with the dynamic nature of the human body, rather than trying to permanently anchor it in place.
We started today by talking about dropping a static piece of steel onto an aging, shifting roof. Maybe the future of medicine isn't about fighting the ecosystem of the human body, but learning how to plant a seed that safely grows, supports the structure, and then quietly fades away when its job is done. Thank you so much for joining us on this deep dive. We'll catch you next time.